Welcome to the Dr. Izzy's Medical Podcast channel.
Menopause. Menopause, also known as the climacteric, is the time in women's lives when menstrual periods stop permanently, and they are no longer able to bear children. Menopause typically occurs between 49 and 52 years of age. Medical professionals often define menopause as having occurred when a woman has not had any menstrual bleeding for a year. It may also be defined by a decrease in hormone production by the ovaries. In those who have had surgery to remove their uterus but still have ovaries, menopause may be considered to have occurred at the time of the surgery or when their hormone levels fell. Following the removal of the uterus, symptoms typically occur earlier, at an average of 45 years of age. In the years before menopause, a woman's periods typically become irregular, which means that periods may be longer or shorter in duration or be lighter or heavier in the amount of flow. During this time, women often experience hot flashes. These typically last from 30 seconds to 10 minutes and may be associated with shivering, sweating, and reddening of the skin. Hot flashes often stop occurring after a year or two. Other symptoms may include vaginal dryness, trouble sleeping, and mood changes. The severity of symptoms varies between women. While menopause is often thought to be linked to an increase in heart disease, this primarily occurs due to increasing age and does not have a direct relationship with menopause. In some women, problems that were present like endometriosis or painful periods will improve after menopause. Menopause is usually a natural change. It can occur earlier in those who smoke tobacco. Other causes include surgery that removes both ovaries or some types of chemotherapy. At the physiological level, menopause happens because of a decrease in the ovaries' production of the hormones estrogen and progesterone. While typically not needed, a diagnosis of menopause can be confirmed by measuring hormone levels in the blood or urine. Menopause is the opposite of menarche, the time when a girl's periods start. Specific treatment is not usually needed. Some symptoms, however, may be improved with treatment. With respect to hot flashes, avoiding smoking, caffeine, and alcohol is often recommended. Sleeping in a cool room and using a fan may help. The following medications may help: menopausal hormone therapy, clonidine, gabapentin, or selective serotonin reuptake inhibitors. Exercise may help with sleeping problems. While menopausal hormone therapy was once routinely prescribed, it is now only recommended in those with significant symptoms, as there are concerns about side effects. High-quality evidence for the effectiveness of alternative medicine has not been found. There is tentative evidence for phytoestrogens. Signs and symptoms. During early menopause transition, the menstrual cycles remain regular but the interval between cycles begins to lengthen. Hormone levels begin to fluctuate. Ovulation may not occur with each cycle. The term menopause refers to a point in time that follows 1 year after the last menstruation. During the menopausal transition and after menopause, women can experience a wide range of symptoms. Vagina and uterus symptoms. During the transition to menopause, menstrual patterns can show shorter cycling, longer cycles remain possible. There may be irregular bleeding. Dysfunctional uterine bleeding is often experienced by women approaching menopause due to the hormonal changes that accompany the menopause transition. Spotting or bleeding may simply be related to vaginal atrophy, a benign sore, or may be a functional endometrial response. The European Menopause and Andropause Society has released guidelines for assessment of the endometrium, which is usually the main source of spotting or bleeding. In postmenopausal women, however, any genital bleeding is an alarming symptom that requires an appropriate study to rule out the possibility of malignant diseases. Symptoms that may appear during menopause and continue through postmenopause include painful intercourse, vaginal dryness, atrophic vaginitis, thinning of the membranes of the vulva, the vagina, the cervix, and the outer urinary tract, along with considerable shrinking and loss in elasticity of all of the outer and inner genital areas. Other physical symptoms of menopause include lack of energy, joint soreness, stiffness, back pain, breast enlargement, breast pain, heart palpitations, headache, dizziness, dry, itchy skin, thinning, tingling skin, rosacea, weight gain, urinary incontinence, urinary urgency, interrupted sleeping patterns, heavy night sweats, and hot flashes. Mood and memory effects. Psychological symptoms include anxiety, poor memory, inability to concentrate, depressive mood, irritability, mood swings, and less interest in sexual activity. Menopause-related cognitive impairment can be confused with the mild cognitive impairment that precedes dementia. Tentative evidence has found that forgetfulness affects about half of menopausal women and is probably caused by the effects of declining estrogen levels on the brain, or perhaps by reduced blood flow to the brain during hot flashes. Mood and memory effects as symptoms. Psychological symptoms include anxiety, poor memory, inability to concentrate, depressive mood, irritability, mood swings, and less interest in sexual activity. Menopause-related cognitive impairment can be confused with the mild cognitive impairment that precedes dementia. Tentative evidence has found that forgetfulness affects about half of menopausal women and is probably caused by the effects of declining estrogen levels on the brain, or perhaps by reduced blood flow to the brain during hot flashes. Long-term effects in menopause. Menopause confers a possible but contentious increased risk of atherosclerosis. The risk of acute myocardial infarction and other cardiovascular diseases rises sharply after menopause, but the risk can be reduced by managing risk factors, such as tobacco smoking, hypertension, increased blood lipids and body weight. Increased risk of osteopenia, osteoporosis, and accelerated lung function decline. Women who experience menopause before 45 years of age have an increased risk of heart disease, death, and impaired lung function. Causes. Menopause can be induced or occur naturally. Induced menopause occurs as a result of medical treatments such as chemotherapy, radiotherapy, oophorectomy, or complications of tubal ligation, hysterectomy, unilateral or bilateral salpingo-oophorectomy or leuprolin usage. Age factor. Menopause typically occurs between 49 and 52 years of age. Half of women have their last period between the ages of 47 and 55, while 80% have their last period between 44 and 58. Premature ovarian failure. Premature ovarian failure is when the ovaries stop functioning before the age of 40 years. It is diagnosed or confirmed by high blood levels of follicle-stimulating hormone and luteinizing hormone on at least 3 occasions at least 4 weeks apart. Surgical menopause. Menopause can be surgically induced by bilateral oophorectomy, removal of ovaries, which is often, but not always, done in conjunction with removal of the fallopian tubes in uterus, which is called hysterectomy. Cessation of menses as a result of removal of the ovaries is called surgical menopause. Surgical treatments, such as the removal of ovaries, might cause periods to stop altogether. Diagnosis in menopause. Ways of assessing the impact on women of some of these menopause effects include the Green Climacteric Scale Questionnaire, the Cervantes Scale, and the Menopause Rating Scale. Premenopause. Premenopause is a term used to mean the years leading up to the last period, when the levels of reproductive hormones are becoming more variable and lower, and the effects of hormone withdrawal are present. Premenopause starts sometime before the monthly cycles become noticeably irregular in timing. Perimenopause. The term perimenopause, which literally means around the menopause, refers to the menopause transition years before the date of the final episode of flow. According to the North American Menopause Society, this transition can last for 4 to 8 years. The Center for Menstrual Cycle and Ovulation Research describes it as a 6 to 10 year phase ending 12 months after the last menstrual period. During perimenopause, estrogen levels average about 20 to 30% higher than during premenopause, often with wide fluctuations. These fluctuations cause many of the physical changes during perimenopause as well as menopause, especially during the last 1 to 2 years of perimenopause. Some of these changes are hot flashes, night sweats, difficulty sleeping, mood swings, vaginal dryness or atrophy, incontinence, osteoporosis, and heart disease. During this period, fertility diminishes but is not considered to reach zero until the official date of menopause. The official date is determined retroactively, once 12 months have passed after the last appearance of menstrual blood. The menopause transition typically begins between 40 and 50 years of age. The duration of perimenopause may be for up to 8 years. Women will often, but not always, start these transitions about the same time as their mother did. In some women, menopause may bring about a sense of loss related to the end of fertility. In addition, this change often occurs when other stressors may be present in a woman's life. Post-menopause. The term postmenopausal describes women who have not experienced any menstrual flow for a minimum of 12 months, assuming that they have a uterus and are not pregnant or lactating. In women without a uterus, menopause or postmenopause can be identified by a blood test showing a very high FSH level. Thus, postmenopause is the time in a woman's life that takes place after her last period or, more accurately, after the point when her ovaries become inactive. The reason for this delay in declaring postmenopause is because periods are usually erratic at this time of life. Therefore, a reasonably long stretch of time is necessary to be sure that the cycling has ceased. At this point, a woman is considered infertile. However, the possibility of becoming pregnant has usually been very low, but not quite zero, for a number of years before this point is reached. A woman's reproductive hormone levels continue to drop and fluctuate for some time into post-menopause, so hormone withdrawal effects such as hot flashes may take several years to disappear. A period-like flow during post-menopause, even spotting, may be a sign of endometrial cancer. Management. Perimenopause is a natural stage of life. It is not a disease or a disorder. Therefore, it does not automatically require any kind of medical treatment. However, in those cases where the physical, mental, and emotional effects of perimenopause are strong enough that they significantly disrupt the life of the woman experiencing them, palliative medical therapy may sometimes be appropriate. Hormone replacement therapy. In the context of the menopause, hormone replacement therapy is the use of estrogen in women without a uterus and estrogen plus progestin in women who have an intact uterus. Hormone replacement therapy may be reasonable for the treatment of menopausal symptoms, such as hot flashes. It is the most effective treatment option, especially when delivered as a skin patch. Its use, however, appears to increase the risk of strokes and blood clots. When used for menopausal symptoms, some recommend it be used for the shortest time possible and at the lowest dose possible. Evidence to support long-term use, however, is poor. It also appears effective for preventing bone loss and osteoporotic fracture, but it is generally recommended only for women at significant risk for whom other therapies are unsuitable. Hormone replacement therapy may be unsuitable for some women, including those at increased risk of cardiovascular disease, increased risk of thromboembolic disease, or increased risk of some types of cancer. There is some concern that this treatment increases the risk of breast cancer. Adding testosterone to hormone therapy has a positive effect on sexual function in postmenopausal women, although it may be accompanied by hair growth, acne, and a reduction in high-density lipoprotein cholesterol. These side effects diverge depending on the doses and methods of using testosterone. Selective estrogen receptor modulators. SERMs are a category of drugs, either synthetically produced or derived from a botanical source, that act selectively as agonists or antagonists on the estrogen receptors throughout the body. The most commonly prescribed selective estrogen receptor modulators are raloxifene and tamoxifen. Raloxifene exhibits estrogen agonist activity on bone and lipids, and antagonist activity on breast and the endometrium. Tamoxifen is in widespread use for treatment of hormone-sensitive breast cancer. Raloxifene prevents vertebral fractures in postmenopausal, osteoporotic women and reduces the risk of invasive breast cancer. Other medications. Some of the SSRIs and SNRIs appear to provide some relief from vasomotor symptoms. Low-dose paroxetine is the only non-hormonal medication that was FDA approved to treat moderate to severe vasomotor symptoms associated with menopause. They may, however, be associated with appetite and sleeping problems, constipation and nausea. Gabapentin or clonidine may help but do not work as well as hormone therapy. Gabapentin can decrease the amount of hot flashes. Side effects associated with its use include drowsiness and headaches. Clonidine is used to improve vasomotor symptoms and may be associated with constipation, dizziness, nausea, and sleeping problems. Therapy. One review found mindfulness and cognitive behavioral therapy decreases the amount women are affected by hot flushes. Exercise. Exercise has been thought to reduce postmenopausal symptoms through the increase of endorphin levels, which decreases estrogen production decreases. Additionally, high BMI is a risk factor for vasomotor symptoms in particular. However, there is insufficient evidence to support the benefits of weight loss for symptom management. There are mixed perspectives on the benefits of physical exercise. While one review found that there was a lack of quality evidence supporting a benefit of exercise, another review recommended regular healthy exercise to reduce comorbidities, improve mood and anxiety symptoms, enhance cognition, and decrease the risk of fractures. Yoga may help with postmenopausal symptoms similar to other exercise. There is insufficient evidence to suggest that relaxation techniques reduce menopausal symptoms.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.